for a discussion on the anatomy of the hand and wrist as it relates to metacarpal and phalangeal fractures. There are 5 metacarpal bones in the hand, connected proximally to the second carpal row through to the C joints and distally to the phalanges through the metacarpophalangeal joints. There are different regions along the metacarpal bones. The most distal part of the metacarpal bone is called the head. The middle portion is called the shaft. The space between the head and the shaft is called the neck. And the most proximal portion of the metacarpal bone is called the base. These different regions are important to remember when discussing the different types of metacarpal fractures. In terms of the phalanges, the thumb has 2 phalanges, the proximal and distal phalanges. All other fingers, from the index to the small finger, have 3 phalanges, the proximal, middle, and the distal phalanx. It is important to mention the key soft tissue structures around the metacarpals and the phalanges. There are muscles, tendon sheaths, tendons, and ligaments. This picture shows the dorsal interosseous muscles, which take attachment points on the dorsal aspect of the hand in between the metacarpal bones. The tendons of the extensor digitorum communis and extensor indicis proprius sit superior to the dorsal interosseous muscles. The tendon sheath covers the extensor digitorum communis and extensor indicis proprius tendons at the level of the wrist. We can also see the articular capsules of the metacarpal phalangeal joints and the dorsometacarpal ligaments. The lumbrical muscles sit on the volar or palmar aspects of the hand and fingers. They originate from the tendon of the flexor digitorum profundus. The tendons of the flexor digitorum superficialis sit right on top of the tendon of the flexor digitorum profundus. These tendons are covered by the common flexor sheath, which runs through the carpal tunnel, and the synovial sheaths of the digits of the hand. Even more superficial lies the palmar aponeurosis, made of longitudinal and transverse fibers, and the superficial transverse metacarpal ligament. All of these soft tissue structures are important because they play a role as the main deforming forces in traumatic injuries of the metacarpals and phalanges. Lastly, there are nerves, arteries, and veins susceptible to damage during metacarpal and phalangeal fractures. The nerves are the proper palmar digital nerves of the median nerve, the proper palmar digital nerves of the ulnar nerve, dorsal digital nerves of the radial nerve, and the dorsal digital nerves of the ulnar nerve. The arteries are the proper palmar and dorsal metacarpal arteries, along with the palmar and dorsal digital arteries. The veins are the median antebrachial vein palmarly and the venous network of the hand dorsally, which branch into the palmar and dorsal metacarpal and digital veins. Thank you for tuning into Orthopaedia. Thank you for tuning into Orthopaedia for a discussion on the biomechanics of the hand and wrist as it relates to metacarpal fractures. There are different regions along the metacarpal bones. The most distal part of the metacarpal bone is called the head. The middle portion is called the shaft or diaphysis. The space in between the head and the shaft is called the neck or distal metaphysis. And the most proximal portion of the metacarpal bone is called the base. These different regions are important to remember when discussing the different types of metacarpal fractures. Soft tissue structures around the metacarpal and the phalanges, including muscles, tendon sheaths, tendons, and ligaments, that in a healthy and uninjured hand enable purposeful motion, can become deforming forces in the presence of fractures. Metacarpal fractures comprise 40% of all hand injuries and are most commonly seen in the male population in the second and third decades of life. The event usually occurs at home or during recreational activities. The mechanism of injury can be a direct blow or contact force to the hand, a rotational injury with axial load, and high energy injuries such as car accidents, which can leave the patient with multiple fractures. The metacarpal neck is the most common site of fracture. Out of all the metacarpals, the fifth digit's metacarpal neck is the most commonly injured. The majority of metacarpal fractures are closed, simple, and stable. As function follows form, there are varying degrees of tolerance for deformity with metacarpal fractures. These fractures are often amendable to simple splinting for a period of time and early mobilization, or closed reduction and immobilization. The fracture should be closely monitored with follow-up x-rays to ensure the reduction is maintained. The surgical indications for these traumatic injuries are as follows. The inability to obtain a closed reduction defines an irreducible fracture. In unstable fractures, closed fracture reduction can be obtained, but cannot be maintained due to unstable fracture patterns, rotation, significant shortening, and deforming forces. In complex intra-articular fractures, it's crucial to ensure the anatomic reduction and stable fixation for the best functional outcome. Multiple metacarpal and unstable fractures are indicated for surgery, as are open fractures because they require surgical debridement of contaminated material to prevent potential infections. Segmental bone loss with severe comminution requires the use of bone grafting and internal stabilization to restore the length and normal biomechanical features. The position of safe immobilization, or the intrinsic plus position, is used for conservative cast immobilization of metacarpal fractures. By holding the wrist in extension of 20 to 30 degrees, the metacarpal phalangeal joint in flexion of 70 to 80 degrees, and the proximal and distal interphalangeal joints in full extension at 0 degrees, with the thumb abducted parallel to the index finger. This position prevents contractures of collateral ligaments and intrinsics at the metacarpal phalangeal, distal interphalangeal, and proximal interphalangeal joint levels. When evaluating patients with metacarpal and phalangeal fractures, look for signs of trauma and check finger length, knuckle contour, and rotational alignment. All of the fingers must point down to the scaphoid when in flexion if no malrotation is present. Evaluate the fingers in flexion and extension. The different radiographs that are obtained to assess metacarpal fractures are the posterior anterior view, oblique view, and the lateral view. There are different options for the lateral view. A true lateral view allows assessment of the third metacarpal. A lateral view with 20 to 30 degrees of pronation assesses the index finger. And a lateral view in 30 degrees of supination is used for ring and small fingers. There are different classifications for metacarpal fractures. Let's review each of these. Classification may be based off the fracture pattern, which may be spiral, oblique, or transverse. Classification may also be according to deformity or angulation of the deformity as a rotational or shortening deformity. A rotational deformity is not tolerated. A rotation of greater than 5 degrees causes digital overlapping of 1.5 centimeters. The fingers are normally parallel in extension and point to the scaphoid tubercle in flexion. In a fracture, the scissoring effect or overlap of the fingers is seen. As for a shortening deformity, it is only acceptable if it is less than 4 millimeters. The deep intermetacarpal ligaments may be torn, revealing step-offs, which can be seen on radiographs. Angulation in the frontal plane is tolerated under 5 degrees. Further classification includes soft tissue involvement and whether the fracture is closed or open. Lastly, fracture locations are classified either at the head, neck, shaft, or involving the base of the metacarpal bone. Let's describe metacarpal fractures more specifically, starting with metacarpal neck fractures. The acceptable angulation of neck fractures of a second metacarpal is less than 10 degrees, and third metacarpal is less than 20 degrees. For the fourth metacarpal, it is less than 30 degrees, and the fifth metacarpal, the acceptable angulation is less than 50 degrees. The ulnar digits can tolerate more angulation because of their inherent degree of mobility. However, grip strength can begin to suffer with angulations greater than 30 degrees. Because of an imbalance with the intrinsic and extrinsic muscles of the hand, malunion of the metacarpal neck fractures with significant apex dorsal angulation can cause digital pseudo-clawing, flexion of the malunited metacarpal head, and extension of the proximal phalanx. Neck fractures are most commonly seen in the ring and small fingers. Street fighter's fracture is a fifth metacarpal neck fracture, also known as a boxer's fracture, because of the direct load on the metacarpal head that often results with landing a closed fist punch. The examiner should be careful to closely examine the skin of the dorsal hand. Often, lacerations occur from punching someone in the mouth. The slang term used for this injury is a fight bite. If not recognized and treated, a fight bite can have serious consequences, such as infections. Treatment options for metacarpal neck fractures are closed reduction and cast immobilization in the safety position for 4 weeks, closed reduction and percutaneous pinning with trimmet pins, intermetacarpal pinning, and open reduction with internal fixation using plates and screws for comminution or unstable fracture patterns. Metacarpal shaft fractures, which usually have an apex dorsal angulation with the intermetacarpal ligaments preventing shortening by more than 3 to 4 millimeters. Malrotation is seen with spiral fractures. These fingers should be assessed in extension and flexion, and it's also important to check the cascade of fingers toward the scaphoid tubercle. The surgical indications for metacarpal shaft fractures are if there is a dorsal angulation greater than 10 degrees for the index and middle fingers, and greater than 30 degrees for ring and small fingers. Shortening of more than 3 to 5 millimeters is another indication for surgery. 2 millimeters of shortening can result in 7 degrees of extensor lag, meaning the finger is lagging in the last 7 degrees of extension. More than 5 degrees of rotation causes 1.5 centimeters of finger overlap with flexion. Multiple fractures are another indication for surgery. Some treatment options for metacarpal shaft fractures are closed reduction with casting or splinting in the safety plus position, closed reduction with percutaneous pinning, intramedullary screws, open reduction and internal fixation with plates and lag screws, and external fixation. Intra-articular metacarpal head fractures are rare and are due to a direct blow or axial load. They're often severely comminuted into small fragments that cannot be fixed. Open reduction and internal fixation has the goal of anatomic articular reduction with the help of trimmet pins or headless screws. Another option is MCP arthroplasty versus fusion for extremely comminuted intra-articular fractures. The thumb carpometacarpal joint has 2 specific fractures that have been described. The Bennett fracture is the most common type of intra-articular fracture of the thumb. It's an intra-articular fracture through the base of the first metacarpal bone. Because of the deforming force of the abductor pollicis longus, there is often some degree of subluxation seen. The Rolando fracture is a comminuted intra-articular fracture through the base of the first metacarpal bone. This fracture is typically T or Y-shaped, consisting of 3 distinct fragments. Again, because of the pull of the APL, the fracture is often displaced. Finally, treatment options for these carpometacarpal fractures include closed reduction and percutaneous pinning, and open reduction with internal fixation. Primary CMC fusion should be considered in multiple CMC fracture dislocations, especially those with significant articular comminution and instability. Discussion on the biomechanics of the hand and wrist relating to extraarticular phalangeal fractures. The thumb has two phalanges, the proximal and the distal phalanx. The other fingers, from the index to the small finger, have three phalanges, the proximal, the middle, and the distal phalanx. Phalangeal fractures are common and occur in work-related and athletic injuries. The annual incidence of phalangeal fractures is 2.9%. These traumatic injuries are more common in men between 20 and 29 years of age. When evaluating patients with phalangeal fractures, classic hallmarks include pain, swelling, and tenderness. Look for signs of trauma. Inspect the soft tissues for abrasions or open wounds. Check the integrity of the flexor and extensor mechanisms and any angular or rotational deformities, although these may be obfuscated by swelling. When making a fist, the tips of the index to small fingers should normally point to the scaphoid tubercle, without any crossover or divergence. The examiner should always compare the injured hand to the contralateral uninjured side. The two-point discrimination test can be used to test for sensation. Proximal phalanx fractures present with an apex volar deformity. The proximal fragment is flexed by the interosseous muscle, and the distal fragment is hyperextended by the central slip of the extensor tendon. With palmar angulation, the extensor function will be compromised with an extensor lag of 12 degrees per 1 millimeter shortening. There will be functional deficit and a cosmetic deformity with greater than 25 degrees of angulation. The majority are treated by functional splinting or buddy taping. Middle phalangeal fractures are due to a blow to the dorsal side with axial force. The flexor digitorum superficialis inserts at the center 2/3 of the middle phalanx. The proximal third is going to have an apex dorsal angulation because the flexor digitorum superficialis flexes the distal fragment. The distal third will have a volar apex from the action of the flexor digitorum superficialis on the proximal fragment. Distal phalanx fractures are due to a blow or a crush injury and can include a nail bed injury. The radiographs to assess phalangeal fractures are the posterior-anterior view, the oblique view, used especially for fractures of the head, and the lateral view. Examine the radiograph for angulation, rotational alignment, and shortening. Fractures of the distal phalanx can be divided into tuft fractures, diaphyseal fractures, articular base fractures, epiphyseal injuries, and tendon avulsions. Extraarticular fractures of the proximal and middle phalanx are transverse, short or long oblique, or comminuted. Most commonly, fractures are spiral or oblique in the proximal phalanx and transverse or short oblique in the middle phalanx. Further classification includes soft tissue involvement, whether the fracture is closed or open, and also fracture location, either at the head, neck, shaft, or involving the base. When discussing phalangeal fractures, it is important to make note of the functional immobilization of the hand. This is called the safety or intrinsic plus position. The wrist is held in extension of 20 to 30 degrees, the metacarpal phalangeal joints in flexion of 70 to 80 degrees, the interphalangeal joints in 0 degrees of extension, and the thumb is abducted parallel to the index finger. This position helps in preventing abnormal contractures of the collateral ligaments and intrinsic muscles. Conservative management of stable extraarticular phalangeal fractures include buddy taping with or without splinting or cylinder casting. For unstable extraarticular phalangeal fractures, surgical treatment includes K-wires, tension bands, screws, and plates. Lastly, surgical indications include a failure of reduction with greater than 25 degrees palmar angulation, rotational deformity, greater than 2 millimeters of shortening, displaced long oblique fractures, and an injury with multiple fractures. A discussion on the general surgical considerations in the treatment of metacarpal and phalangeal fractures. Indications for surgical treatment include displaced intra-articular fractures, polytrauma, severe soft tissue injury, unstable open fractures, segmental bone loss, multiple hand or wrist fractures, and irreducible fractures that redisplace following reduction, or which are subacute greater than 3 to 4 weeks from injury. Surgical fixation methods for metacarpal and phalangeal fractures include closed reduction and percutaneous pinning with K-wires, external dynamic fixation, intramedullary screw fixation, lag screws with or without a neutralization plate, and plating. Closed reduction and percutaneous cross pinning is commonly used for metacarpal neck fractures. The goals for this double Kirschner wire fixation are to maintain the fracture reduction, to prevent shortening, and to avoid loosening of rotational alignment by engaging opposite cortices. This fixation technique does not provide a rigid fixation and is commonly associated with pin track infections. The closed reduction and intramedullary pinning, or bouquet pinning, has been utilized for metacarpal shaft and neck fractures. The basic principle of this technique is to obtain a closed reduction of the fracture, followed by filling of the medullary canal with multiple metal or absorbable wires. This multiple intramedullary fixation controls shortening and fragment rotation, but does not have the ability to offer good compression across the fracture site. The use and indications for external fixation in the hand have decreased with the advent of straight and variable angle locking fixation. The old-fashioned frames assembled with Kirschner wires and methyl methacrylate, or the more technologically advanced with threaded pin screws, rods, and nuts, are cumbersome and uncomfortable for patients. Great care needs to be taken to prevent local infection at the insertion points. They can still be temporarily used for complex open fractures to allow for soft tissue management, then the frames are removed and internal fixation is provided. One of the current trends of fixation for stable fracture patterns of the metacarpals is the use of intramedullary headless screws. They may be placed either retrograde or antegrade. The benefits of using these intramedullary screws are that it's a simple technique with a limited approach that minimizes operative scarring. There's no prominence of hardware into the soft tissues of the flexor or extensor tendons, as the fully threaded compression screw is buried inside the bone. It is a stable fixation for non-complicated transverse fractures. Early motion is well tolerated, and even a 4 millimeter screw can fit down the fifth metacarpal. Some limitations to these screws are that they are not indicated for long oblique fractures, as there might be potential rotation of the fragment. As for the possibility of cartilage damage on the metacarpal head, recent studies are showing no cause for concern of potential osteoarthritis later in life. A study by Ten Berg and others showed that there is no statistically significant damage to the articular cartilage once the sagittal or extensor hood is opened at the MCP joint level and the screw is inserted into the metacarpal head. Dorn and others recently studied retrograde headless intramedullary screw fixation for displaced fifth metacarpal neck and shaft fractures in 9 patients. Outcomes were very good, with 0 degrees of extension and 90 degrees of flexion, defining essentially functional range of motion, and also with a very low dash score. As a rule of thumb, the lower the dash number, the better the outcome. The mean postoperative grip strength of the injured hand compared to the uninjured hand was nearly the same. For an unstable long or short oblique fracture, lag screws give the greatest compression and fixation. Ideally, the lag screw must be perpendicular to the fracture line to achieve the strongest lag effect. If the fracture line is very long, the recommendation is to use more than one lag screw. Over time, however, Lag screws undergo fatigue during rotational forces while absorbing axial and bending loads. By combining lag screws with the use of a neutralizing plate, the construct may be enhanced as the plate absorbs and neutralizes those axial, bending, and rotational forces. Although most commonly used on metacarpals, here we see an example of lag screw fixation combined with a neutralization plate on a proximal phalanx fracture. Any plate can serve as a neutralization plate. Here, a 1.6 millimeter Z plate is used with lag screws. Fixed and variable locking fixation. These technologies aim to prevent screw toggling while creating a single beam stiff construct. The screw head gets locked and flush with the screw hole. As opposed to conventional plating, locking constructs preserve periosteal vascularity and distribute the load evenly, preventing weak links. Fixation constructs usually combine the use of locking and conventional screws. The locking screws function as the stiffed post on one end, while the conventional screw adds the longitudinal axial compression when driven through a dynamic oblong hole. Locking screws fail in parallel, while conventional screws fail in series. With rotational, bending, and axial forces, conventional screws toggle within the screw path and loosen. Locking screws and plates, on the other hand, must fail as a unit. Locking mini plates come in a variety of different lengths and sizes depending on the severity and type of fracture. In unstable intra-articular metacarpal head fractures, the use of a triangular variable locking plate, along with K-wire fixation, like trimmet pins, provide a strong support to the two split fragments. This next patient had 3 metacarpal neck fractures fixed with a combination of mini fragment plates, including a triangular monkey plate, and 2 T-plates. Bone void fillers, to act as a substitute, should be considered where a good amount of bone has been lost. A Z-plate is shown on this case of metacarpal shaft fracture. This plate allows the staggering of screws along the small tubular bone. On this 5th metacarpal fracture, the base is split into 2 intra-articular fragments. A 1.6 millimeter triangular plate is used to reduce the fragments. Close attention needs to be paid to proper reduction of the articular surface before committing to the final fixation. For comminuted displaced fractures, as on this proximal phalanx, open reduction and internal fixation may be obtained using a T-plate combined with lag screws positioned out of the plate. The lag screws are placed perpendicular to the fracture line, while the plate acts to neutralize the deforming forces. In this complex fracture of the proximal phalanx, a K-wire clamp is used to initially stabilize the fracture fragments and to regain reduction with a K-wire. A triangle plate is then placed and the K-wire is removed.